Excuse me, ladies and gentlemen, we now have our presenters in conference. Participation in this presentation is by express written invitation of the AHA only. Unauthorized participants and/or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off the webinar if the AHA did not expressly invite your participation. Please be aware that each of your lines is in a listen-only mode. During today's presentation, we will open the floor for questions or comments. At that time, instructions will be given as to the procedure to follow if you would like to ask a question or give a comment. It is now my pleasure to turn this call over to Veronica Riley. You may begin.
Hello, everyone. Welcome to today's program titled Inclusive Local Hiring, Building the Pipeline to a Healthy Community. My name is Veronica Riley, and I'm the director of AHA's Workforce Center, and I will be serving as today's moderator. This webinar is part of a series of workforce webinars that we began hosting late last year. We are pleased to co-sponsor today's webinar with the Association for Community Health Improvement, an affiliate of the American Hospital Association. Today's program focuses on the important role that hospitals play in their community in transforming their approach to workforce planning and development. The Democracy Collaborative's resources, which we will learn more about today, explore how health systems can develop an inclusive, local hiring pipeline through creating more external community connections and internal career paths. We will also hear about University Hospital's experience in their community of Cleveland, Ohio, that continues to work in partnership with community-based organizations to connect local and diverse residents from disinvested neighborhoods surrounding the institution to available frontline positions, and then intentionally aligning internal career development and advancement opportunities. To give us their insight and experiences, we welcome our presenters. David Zuckerman joined the Democracy Collaborative team in 2012 and serves as Director for Healthcare Engagement. David leads the coordination of the Healthcare Anchor Network, a health system-led collaboration focused on improving community health and well-being by building inclusive and sustainable local economies. The network includes more than 35 health systems to date. David is the co-author of the Hospitals Aligned for Healthy Communities Toolkit series. His work focuses on inclusive and equitable economic development strategies that build wealth in low-income communities, with specific attention on how hospitals and health systems can deploy the business side of their institutions to support community health improvement and strengthen their local economies. Debbi Perkul's career has spanned several fields, ranging from education and administration to workforce development. Debbi currently works as a consultant in this field, but previously she was the team leader that developed and implemented local hire programs for university hospitals in Cleveland, Ohio. Over 8.5 years, workforce development grew from a concept into an award-winning, multi-tiered program. Debbi began the initiative as a single program and grew it to become a nationally recognized people strategy that has been adopted across UH's 26,000 employee system and is now embedded in the Human Resource Department's strategic plan and the system-wide culture. Debbi is currently traveling around the world with her husband, but proudly calls Cleveland, Ohio, her home. We're so glad you're able to join us today, Dave and Debbi. Dave, I will turn the program over to you.
Thanks, Veronica, for that kind introduction, and good afternoon, everyone. I want to begin by offering up shared goals that I think all of us in healthcare hope to see: healthy, vibrant, and empowered communities, longer life expectancies, and good physical and mental health for those we serve. Institutions and organizations in the healthcare sector and in America are increasingly accepting these as outcomes we want to achieve and recognizing that we are still falling short. Through this evolution, healthcare is being forced to go outside its walls and ultimately to ask different questions about what are really the most effective strategies to achieve these goals and ultimately sustain them. This webinar will focus on one strategy to help hospitals get there: inclusive local hiring, building a pipeline to a healthy community. It alone won't be enough, but I think it is a necessary component of creating healthy, thriving communities. Many of us on this call know the challenges we face in achieving the outcomes I mentioned. The life expectancy gap between neighborhoods a few miles apart is staggering. This slide depicts a 24-year life expectancy gap between neighborhoods just 8 miles apart in Cleveland, Ohio. The Huff neighborhood on the left is urban and nearly all African American and low income. Lyndhurst, the one on the right, is a first-ring suburb that is mainly white and affluent. Again, you could create a slide like this for most cities across the country in which historically marginalized communities are next to white ones but entirely isolated, in which low-income neighborhoods are next to high-income ones. What is striking about the Cleveland context, I think, is that Huff is proximate to two world-renowned healthcare institutions, University Hospitals and Cleveland Clinic, yet their neighbors have some of the lowest life expectancies in the Cleveland metro area. I think this begs the question of why. Because those institutions have not in the past actually sought to address those factors that most directly have an impact on the health and well-being of those communities, economic factors strongly impacted by racial disparities. Our conversation today, I think, is the story of how the pivot to address those factors is beginning, how healthcare institutions are recognizing the need to evaluate their assets differently in terms of how they can be leveraged, how they can leverage them to improve community health and well-being while operating in an environment of constrained resources. It's not about spending more. It is about being more intentional with the current set of resources. And I think the reason for the urgency is that the numbers aren't getting better. Child poverty in the U.S. has not budged. Concentrated poverty has doubled since 2000. The wealth gap between whites and blacks and whites and Latinos has actually increased from already staggering levels since the Great Recession. And all this has contributed to the gap in life expectancy, one of those goals I mentioned earlier, between the wealthiest and poorest actually having doubled since 1970. Solving these incredible challenges could easily become a story of communities thinking they need to hoard resources and be exclusive, of division and further inequity, of scapegoating and discrimination, of that's their problem, and I put their in quotations, and ultimately of resignation that the challenges are too great to solve, so we should only do for those like us. But the path forward is actually one of inclusion, of collaboration, of working more intentionally with the resources we have to benefit the lives of all those in our communities, with specific focus on those most disadvantaged, to meaningfully improve their health and well-being in the process. Health systems are powerfully positioned to contribute to a vision of equity and inclusion that unites and strengthens their communities. They can engage in a way that increases local empowerment and participation. However, to achieve these outcomes does involve asking a different set of questions than we have in the past. At the Democracy Collaborative, we offer a framework called community wealth building that can hopefully guide communities in this process. It involves asking new questions about how to leverage the many assets we already have in place. It acknowledges the importance of broadening ownership as a necessity for a thriving local community, widespread prosperity, and improved health and well-being. And it is a process of acting local with unusual suspects to stitch together a new ecosystem of support for sustaining and building community wealth and improving community health. For the past 6 years, I've been leading the Democracy Collaborative's healthcare engagement strategy. Part of it now includes directing the Healthcare Anchor Network, which I'll talk about later on. Anchor institutions are a key local asset for building community wealth that have historically been untapped for this purpose. We often overlook this fact, and let's say you're in a college town in which there is no avoiding realizing it, but in almost every community across the country, the largest employers are these nonprofit or public institutions that can't pick up and leave: hospitals, universities, public schools, local government. Obviously, today I'll focus most on how this is playing out with healthcare systems and hospitals across the country. But if you do a Google search for the largest employers in your community, all of these will be in the top 10, and in many communities, they top the list. These anchor institutions are the path to the middle class for many in the 21st century, but the path for getting there is not always as clear and straightforward as it might have been for someone getting a factory job right out of high school decades ago. So it's going to take more work on behalf of institutions to realize their economic benefit for local communities. It won't happen by accident for those neighborhoods and residents most excluded. Many organizations are de facto anchor institutions, but an anchor mission really is about how an institution intentionally seeks to apply its economic power with its people assets in partnership with the community to mutually benefit the long-term well-being of both. This isn't about doing to community, but it does require a very clear focus by the organization and often a level of internal realignment first in order to be a better partner externally. Intention is a word that I'll keep coming back to throughout this presentation. Is that an income implies mutual benefit. We have to be honest about why institutions do what they do. The shift in thinking with adopting an anchor mission is that the benefit for community is intentionally considered along with the benefit for the institution. This might seem obvious, but many residents of communities adjacent to institutions will note that this is often not the case, sometimes intentionally so, and significant distrust often exists between those communities and their institutions. But this shift is in the interest of a healthcare system, since a healthcare institution won't succeed long-term if social and economic inequities continue to grow and the health of the community it sits in continues to decline. I think Debbi's presentation later on will help more clearly lay out how these strategies can be a win-win. So what do I mean by economic power? Health systems have many assets. In this case, I'll be focusing on how does a healthcare system bring to bear the business and operations side of their organization to benefit low-income residents of their community. I highlight it mostly in the bottom right box on the screen. This is what the Hospitals Aligned for Healthy Community Toolkit series sets out to do. Created with the support from the Robert Wood Johnson Foundation, the toolkits are designed to provide hospitals and health system leadership and department managers with the steps to begin to harness their everyday business practices to drive community health and well-being. Our hope is that these toolkits will help to integrate community health principles into health system core business functions and provide interactive resources to accelerate this approach at your institution. For example, how does spending more in the local community with businesses that provide good quality jobs and then intentionally work to create opportunities for residents most left out of the current economy? How do healthcare institutions take their investment portfolios and endowments and not just invest on Wall Street, but in their community in a prudent manner that addresses key social determinants of health, affordable housing, access to affordable healthy food, community health centers? And finally, what we're talking about today, how do health systems do inclusive local hiring, not just creating a pipeline outside in into frontline positions for disinvested communities, but then also creating the path in up from frontline positions to those that pay better and help folks to the middle class. Today we're talking about inclusive local hiring, building the pipeline to a healthy community. The toolkit focuses on two core ideas, outside in and inside up. Outside in seeks to create alternative pathways from your community's hardest hit neighborhoods into open jobs at your institution. It implies an intentional focus on geography, even considering zip codes of highest need, and places an emphasis on equity and diversity in the process. Inside up aims to connect those frontline workers to intentional pathways for career advancement within the institution. So what are those steps from those frontline positions up to family supporting wage roles in the organization? On this slide and the next, I list out key strategies that we uncovered from our many interviews and research for each of these ideas. None of them are particularly surprising, but they underscore the importance of intentional policies and practices and the need to engage internally to effectively implement. So for example, with key strategies for outside in, it's very important to work with a workforce intermediary and to help those partners in the community better understand your institution's needs so that they can be more effective partners in training residents and connecting to the neighborhoods in which they work. Another for key strategies for Inside Up is helping to actually map that process for new hires so they understand what their options are, and then also providing wraparound support for harder to employ new hires. And Debbi can talk more about that as well. But not listed on these two slides, and I think are some of the key intangible factors for most outside and inside of strategies to be successful. So for example, leadership is important. I don't think anyone disputes that in kind of articulating this as a priority internally, but it is not enough for there to be a directive top-down if internally there aren't champions and advocates within the ranks of hiring managers. So many of these strategies can get stuck very easily if the process if there isn't engagement across the process of who actually is needed to make these different efforts work. So all of the toolkits, including this one on inclusive local hiring, can be found at hospitaltoolkits.org, and we're happy to mail print copies to anyone on the call. So in 2016, the Democracy Collaborative and 7 health system partners helped organize a convening in Washington, D.C. to explore the idea of a national health system-led network focused on deepening the understanding about the importance of these strategies and also working to help scale implementation. At the beginning of 2017, the Democracy Collaborative worked with the founding 11 members to develop a sustainable, ongoing, and flexible collaboration framework for the network. And we help coordinate its activities and serve as the backbone. I am excited that we are fast into year 2, and we now have more than 35 health systems participating from across the country. And the network is really focused on improving health and well-being by building inclusive and sustainable local economies. The purpose is to help each participant more rapidly and effectively advance this idea of an anchor mission, as I've defined it today, within their institutions, the communities they serve, and across the healthcare sector. And our long-term goal is that a critical mass of health systems adopt this approach as an institutional priority to improve community health and well-being by leveraging all of their assets for equitable local economic impact. In particular, we are focused on advancing the economic inclusion practices and strategies around local hiring and internal workforce development, inclusive local purchasing and construction practices, and place-based impact investing that I talked about earlier. I believe that the network has become the home for the importance of economic inclusion in healthcare and how these practices can continue to mainstream despite the many competing priorities in the sector. Achieving healthy communities require it. The potential for impact is significant. We often don't think in these terms about the resources we have to deploy to improve health and well-being. But healthcare nationally has 5.5 million employees, $350 billion in annual spending on goods and services, and more than $400 billion sitting in investment portfolios. The numbers on the screen reflect those resources of those who are just participating in the network. So it's a significant part of the economy. I don't need to tell anyone that. We're reminded about it every day in the news. But to get better outcomes in our communities, we need to think differently about what it means to produce health and well-being. And it compels us to be more intentional with the current resources we have. In the interim between the twice-annual gatherings of the network, we currently have 8 ongoing initiative groups that meet remotely each month around specific work products that will be further refined at those in-person meetings. And our hope is that the initiative groups of the network, determined by our health system partners, are driving meaningful products that help advance the network's goals. One of them is focused on connecting practitioners around the topic of inclusive local hiring and helping to create collective resources that each can use in their organization. Through our network, we hope to achieve the activities listed here. My perspective is that an anchor mission framework allows health systems to not see issues of diversity and inclusion, environmental sustainability, community benefit, population health, community health, all of these efforts that are focused away from what has historically been considered the core operations of healthcare, not to look at them as competing priorities, all vying for limited attention, but instead as all necessary prongs of an institutional strategy for improving community health and well-being that is 100% mission aligned. So before I turn it over to Debbie, I want to offer one final thought. One of the sections of our toolkit is called Big Questions, and to be frank, I think given this moment in our country's history, asking big questions is more important now than ever. They help guide our vision and values, and they inform our strategy and implementation, and ultimately whether our strategy and implementation reflect our stated vision and espoused values. So when we talk about inclusive local hiring or any piece of an anchor mission strategy, I think it is really critical to get clear on definitions of local, community, and both mission and business case for this work. if we're going to see meaningful impact in improving the health and well-being of the communities your institutions serve. So thank you again for your time and attention, and I'll turn it over to Debbie now to continue the presentation.
Great. Thank you, Dave. I wanted to start off this conversation to talk about really the people impact of the healthcare network and the Greater University Circle Initiative. Doing the work at university hospitals for 8 years and starting our local hire in 2013, we saw the human impact that these kinds of programs have in that we work with individuals who obtain jobs at the hospital, and over time, with a stable income and continued learning experiences and professional growth, they got into jobs where they could sustain their families, their own personal health got better, they were able to take care of medical problems, and they also provided being role models for their own families, helping their own children with their homework, helping their children graduate and go on to college. And so what we saw was that the impact is multi-generational and can start a process of getting people to sustain their families and their health and bring their families out of poverty, which was really, really gratifying. So in Cleveland, we had the Greater University Circle Initiative, which is a multi-anchor partnership. In University Circle, we have university hospitals, the Cleveland Clinic, and Case Western Reserve University. And we all got together and we decided that if we could hire people that are in our neighborhoods, which are very high poverty neighborhoods, and we can provide a way for people to get into our healthcare system, we would be able to help our neighbors and then also help ourselves. And so we chose the specific zip codes, thinking that people who live in these zip codes may be challenged by the established recruitment process. And so we created this program called Step Up to UH. The key strategies of our local hire were to have a specific pinpoint geographic focus, and it was part of the larger Anchor Institution Initiative, which was included Buy Local, Hire Local, and Live Local. And each one of those prongs had multiple programs associated with it. And so our local hire was just a small part of the much larger Anchor Institution strategy. We had a lot of partners, both internal and external, but our external partners were this workforce intermediary and then other community organizations that had contact with our neighbors and then local educational institutions. We also set aside a specific number of positions that were for the cohort graduates in target departments, and we had a job coach for the new hires for retention, and we linked our internal career development programs with our local hire so people could get hired into the system, and once they were onboarded and maintained their employment, they would be able to come into our other career development programs and get coaching. This diagram is from the Democracy Collaborative Toolkit that you can look at, and it's really hard to read, but I didn't put it up so you could read it. I really put it up so you could see how complex a local hire can be and what Dave was talking about with outside in and inside up. Because inside the hospital, you can see there's multiple tiers of people that need to be involved in a local hire. And then external to the hospital, you can see that there's multiple partners and stakeholders that should be involved in this type of initiative. For Cleveland, in our healthcare hire local initiative, we had some key external partners. The first one is a convener. The convener is a neutral party that can bring together the top-level executives of the anchor institutions to bring them together and get their buy-in and adoption of a hire local strategy. In this case, in Cleveland, it was the Cleveland Foundation. And we formed a committee of a hire local, and every month we would meet and talk about what we could do to hire people from our target neighborhoods. And then this convener, the Cleveland Foundation, also provided seed funding for a pilot program. We also had Cleveland State University acting as our research and evaluator. And that was really key to find out how many people were the different anchor institutions already hiring from the target neighborhoods, helping us set goals of what we would want to hire from the neighborhoods, how many people, and did quarterly reporting so that we could be updated on our progress and what impact we were having with our initiatives. A workforce intermediary is Towards Employment, and Towards Employment Act is a nonprofit organization that helps with workplace readiness, work readiness, and retention services. And they provided us with an array of services, including work preparation and retention services for the people that we hired. And then we also had another organization called Neighborhood Connections, which is a grassroots community organization, and they have strong ties to our target neighborhoods and have the legitimacy to gain our neighbors' trust, so they would know that what we were doing was legitimate and we could be trusted. Internally, we have key staff that have to be involved and in order for this to be successful. First of all, we have to have talent acquisition involved, and to reach the very top of talent acquisition, at UH we had our Vice President of Talent Acquisition, who was not only a champion of the program, but really drove it to its continued growth and development. And then also she was able to cascade her ideas down to the talent acquisition managers and recruiters who were really implementing and executing the plan. We had the target departments, which were in our case environmental service and nutrition services, as our pilot program. And from the directors of those departments, cascading down to the hiring managers was really important. And then we had our community engagement leaders and then a workforce development team, which grew over time. It started just with me as a workforce development leader, and then grew to a career coach, and then our workforce intermediary provides an on-site job coach, which I'll get more into later. And so this is a really simple graphic that shows you how the program works. First of all, we worked with, at the bottom, Neighborhood Connections went out into the neighborhoods to tell people about the opportunity. Towards Employment held information sessions, had people apply to the program, and selected people for it, and then held a pre-employment class. While people were in class, the target departments from university hospitals went to the class to talk about employment and culture so people would really know what they were getting themselves into and be prepared. At the end of the class, a UH recruiter went on site and to do interviews with the people and then passing people on to the hiring managers. And then after the hiring manager interviewed and selected, they were onboarded, and then a Towards Employment job coach would be on site to help people with their retention over time. As I said, the seed funding for this came from the Cleveland Foundation for the pilot, and as time went on and the programs grew, university hospitals continued to put more money into this and grow the program, and we were also able to gain the interest of other foundations and philanthropic partners. And we were also able to leverage funding that our community partners had that they were using to fulfill their mission. They were able to help us and put some to help with the program. And so what were the elements of success? First, one thing that was really the brainchild of our Vice President of Talent Acquisition was that we would have specific job openings that the program graduates would apply for. And so they would be basically a funnel before the funnel and put into, they would be competing for a specific job requisitions. The second thing, and I can't emphasize this enough, is the close and ongoing collaboration and communication of all the partners. We had ongoing meetings all the time, and there were always phone calls going back and forth to make sure that things were going smoothly. Having the recruiters go on site to Towards Employment is really a great strategy so that people don't get lost, and I put that in quotation marks, going from application to interview. And also the recruiter then gets a sense of the type of people who are applying, the programs that they went through, and can really better appreciate the talent and skills that the applicants can bring to university hospitals. We use a cohort model, which is really important for peer support. And so everything is done as a cohort, from the training, from the pre-employment program to the onboarding and meeting with a job coach also. In order to do this program, we actually had a pre-planned calendar of program execution, including orientation sessions, hiring dates, onboarding, etc. And we had continuous checkpoints to make sure that everybody and all of the partners were adhering to the calendar. And if things started to fall apart, we could immediately troubleshoot to make sure that things could get back on track. I've already mentioned the on-site job coach, but really key for just-in-time coaching. If somebody was having a problem at the work site, the job coach could talk to the manager and the employee and try to figure out what was happening and help smooth out whatever bumps were on that road. And then we also had regular report outs to stakeholders, which was really key for continued buy-in. And so what were the lessons learned? The first thing is that having an internal employee who really can understand the recruitment system, as well as have relationships with all of the key internal partners, from the hiring managers to the recruiters, recruiter manager, and also be able to talk to the new employees is really essential. Having an on-site presence of that external job coach, as I've already spoke about, is really important. And having that job coach have access to the managers for regular check-ins, and also have the managers have the phone number of the job coach so they can call and say, Mary was late for work 3 times. Could you help us figure out what's going on, or something like that, which happened occasionally. Communication is really important, and that's something that I did in my job a lot. Checking in with the managers, checking in with Towards Employment, checking in with the leadership to make sure that people were happy with how things were going, making sure that communication was flowing between our external and internal partners, and the ability to have our leaders cascade their communication as this program being a priority to their team is really important. Because if the director likes the idea, but the hiring manager is a little reluctant, then it's not going to work. And so we really had to build trust and buy-in at all levels. And if the recruiter doesn't understand the program, then that also is a way that it could not really work out. And so we have to make sure the recruiters also understand what's happening. As we were building the program and developing new pathways and new job categories that people could get hired into, I had to go and talk to different leaders to see if they would be interested in participating. And what I learned is that a no today could be a yes tomorrow, because as the program grows and is successful, people are much more willing to give it a try if they see that other people have been successful with the program. And so that was a really good learning for me. The calendar and timeline is really important also for gaining trust, because if you tell a hiring manager that people are ready to go at a certain date, and then they really are, then you build a lot of goodwill. And finally, reporting out results is very, very important, because not only do the hiring managers and the leaders want to know how things are going, but also getting other people on board and supporting is really important. And the reporting out can be both internally to your stakeholders and externally, because reporting out externally can help leverage more funding for growing the program. And one of the things that we did with the Cleveland Foundation as we were growing the program is keeping in very close contact with our partners there, letting them know not only how things were going with our current program, but also our ideas of how we wanted to expand and scale up the program so more people could get hired in the hospital system. So that's, in a nutshell, everything that happened as we were starting up Step Up TUH. And the very last thing I'll say is that once people were hired in, we connected them to our internal development programs, and people were able to go from environmental service worker to patient care assistant to maybe administrative support, or they went back to school and got other skills and continue to move up the career ladder. So it's ongoing, and people are continuing to grow in their careers. So that's it. And, thank you.
Debbi, before we get to questions, there's one thing that I always have heard you say that I think is a really important takeaway and point for this work, with regard to a local hiring strategy is only as effective as the internal workforce development programs that complement it. Do you want to briefly build on that?
Oh, sure, absolutely. So if we have a certain number of positions that we want to have our local neighborhoods fill, once they get into their positions, they tend to have equal or more higher level of retention. And so as time goes on and retention goes up, there's less positions for people to go into. And so we'll have a problem because we won't be able to hire so many people because positions are all taken. And so what's really important is that as people get into employment and prove themselves to be great employees, and they can see what their possibilities of what they can do, that they can plug into our internal career development program and move into other positions at a higher level, and then that clears the way to backfill with our local hire people. So we're able to have a career coach who can offer career development opportunities, help people understand where they can go in our system, connect them to further training opportunities, and move up a career ladder.
And I think one additional comment I'll add to that as well is that I think part of this approach and also part of the community wealth building approach that we advocate for at the Democracy Collaborative is really this idea of flipping the script around workforce development historically, which has been, as I heard recently, it was actually the governor of Rhode Island say that the approach used to be train and pray. And we would do workforce development programs and hope there's a job at the end of the pipeline. Part of this approach and the importance of working with large health institutions and including health systems is the ability to kind of work backwards from the needs of large employers and with an intentional approach towards those pipelines, so that the resources available in communities to help large employers with these programs can be more effectively deployed for the benefit of both community residents as well as the large employers in the community. So we'll toss it back to Veronica to moderate the Q&A.
Fantastic. Thank you, Dave and Debbi. Great comments, and thank you for both of those great presentations. We'll open it up for questions and comments from those of you who are listening in. You may use the chat box, the Q&A box, to submit questions online. And for those of you who are dialing in by phone, you may ask your questions via the phone. And Chantel, can you please let everyone know how they can do that?
Yes, thank you. Ladies and gentlemen, at this time we'd like to open the floor for questions. If you would like to ask a question, you may press *1 on your touch-tone phone now. Again, that is *1 to ask an audio question.
Perfect. Thank you. While we wait for folks to type in their questions or dial in, Dave, I just have a question for you in terms of the Anchor Network. Are you, is the Democracy Collaborative accepting applications from new potential members for that engagement work that you guys are working on?
So the Healthcare Anchor Network is a health system-like collaboration in the sense that it's the infrastructure for the network is being supported through the contributions of the different health systems in it. So we are definitely, the goal is to continue to grow the network, and we are acting as the backbone to help make that possible. So the short answer to your question is yes, but I do want to give that context. So.
Okay, perfect. And if folks are interested in becoming part of that, there's more information on either one of those websites that is on the screen in front of them, or what's the best way to get some more information?
Sure. If anyone's interested in learning more about becoming a Healthcare Anchor Network member, you can reach out to me at daviddemocracycollaborative.org, and I can send you more information directly. There's also more of a description at healthcareanchor.network, which is the main website for the collaboration. And you can read more about there and see the other health system members. All of their logos are up on that website.
Okay, perfect. Thank you. Chantel, do we have anybody who has dialed in with a question?
At this time, we have no audio questions.
Okay. And I don't see any in the Q&A chat box either, which is fine. Debbie, I have a...
You do actually
have
questions in the queue?
Yeah.
Oh, for some reason, I don't see them.
That's all right. I can go ahead and read them. David, are you able to see them?
That's okay. I am now seeing them. I had pushed the wrong button. I am sorry. I'm very sorry. I now see them, which is great. So let's go to Mark Sherry's question, which is, what is the length of the entire interview process? And I guess that would be a question for Debbie.
Sure. Excuse me. So the interview process, the actual interview process is really short. It's basically at the end of the pre-employment training program, the recruiters go in one day and they interview all of the graduates of the program, and then they go to the hiring manager like the very next week, and they interview one day, and then that's it, they're hired. The actual process from the time of the recruitment information session before the pre-employment class to the end of the pre-employment class is many weeks. It's about 8 weeks, I believe, from the beginning to the end of that. But the actual interview process is very, very quick.
Okay. Another question. How many people have been hired through the program? Did that meet your goal?
So we actually exceeded our goal in our hiring. I can tell you that in the pilot program in 2013, our goal had been to hire 7 people just to try it out. And when the hiring managers interviewed all, I think there were 15 graduates of that first pilot program, we hired 13 out of the 15 instead of 7 because they were so impressed with the graduates. For the first 2.5 years of the program, we hired 111 people, and we had, for the first year, an 80% retention, which was comparing to a 66% overall departmental retention rate. So that was a really big, and so over the years, we've expanded this to other job categories. When we did our PCA, we had 55 hires over the first 2 years, and the program is still ongoing, so there's many more people that have been hired. And and we met our goal. We've exceeded our goals.
Yeah, absolutely. It sure sounds like that. Okay, another question from Nicole. How do you engage underprivileged neighborhoods?
So I'll answer that for Cleveland, and then Dave, maybe you can take it for other, if you would want. So in Cleveland, we used our partner Neighborhood Connections, who have very, very strong ties in the community. They have something that's called Neighbor Up Night, where once a month they go to different locations in the neighborhoods and they have community building activities and meetings. And it's all about empowering people. And so they have a lot of trust and engagement in the neighborhoods, and people know them. And so they're our first point of contact for this program. And then towards employment, our workforce intermediary is a very well-established organization, and people really know them. So using those two organizations has built a lot of trust for us.
To build on Debbie's comments, what we've seen from other healthcare examples is that the most successful examples are the ones who engage as intentionally and authentically with community-based organizations in this work. It is demand-driven in the sense that, as Debbie was articulating, there are needs that the health system has, but the ability to match those needs and to understand the assets that are in the community will best come from those who are working and living in the community. And so that's been, I think, a constant theme throughout the best or most promising practices in this area, as well as the other strategies that we look at in the Healthcare Anchor Network.
Okay, thank you. Another question, what is the percentage of your retention, or what's your retention rate then?
Mm-hmm. Yeah, so it fluctuates depending on the cohort that comes into the system. But we were ranging from 100% retention down to like 80% retention. We never really went below 80% in the first few years of the program, and we measured retention at sort of a traditional 30, 60, 90 days, and then we looked at retention after 1 year, and we also looked at after 1 year how people moved up into new jobs, and that also was increasing over time as people were becoming more aware of the opportunities available to them.
And then in terms of the size of the cohort, that's dependent on how many jobs were available at that time, right? I mean, it wasn't that you had a certain amount in each cohort. It was dependent on what the opportunities were.
That's correct. However, we and this was something that was refined, and I believe probably is still being refining now, is how to stagger the classes between departments and also over time, so that we would have a critical mass of people who could be in a cohort and have the number of job requisitions available for them. We, in the beginning, we played around with, should we just hire environmental service people this round and then the next round do nutrition services, or should we do half and half? And we tried a little bit of both, and then we liked doing half and half because it wasn't then a big burden to hold requisitions open for the specific departments, meaning you could just sort of split between those two departments and have a critical mass of people. And also having departments where there's a large volume of people, like patient care technicians, for example, you would tend to have spread over the system quite a number of openings that could provide that.
Debbie, could I ask a question follow-up on that? Taking that example and perhaps applying it to less urban communities or suburban or rural communities where there might not be that critical mass of positions open at any one time, what would you say would be the smallest size cohort you would want to pursue? And then, and if you don't have that amount of open positions, what do you see as some creative strategies to either working with other healthcare systems or other ways to kind of, as you were saying, get to that critical mass but not hold positions open?
But I think that if you are in a setting that isn't an urban setting, you have to change your model a little bit. For one of our more rural hospitals, we tried a number of different strategies working with different workforce intermediaries, and the way that we did it was because they didn't have a large number of openings, but those openings were critical. And then there also weren't a lot of people to bring in because there's not that many people around. And so we did more as needed, where our partner organization would do some training with people, and as they finished and a position was open, they would send them for an interview. And we were able to fill some positions that way. The scale is much, much smaller, and we struggled a little bit with that. In the end, we hired some really good people, but it just presents a lot of different challenges and takes different types of strategy, continued engagement with the partner, but it's not as active because the volume was much, much lower. Hopefully that answers your question.
It does.
Yes, I think that's helpful. Yeah. We have another question. Was there concern with skills gaps from the hiring managers or the recruiters? And if so, do your partners help with training to close the skills gap?
Yeah, that's a really good question. So, excuse me, the first two departments that we worked with were environmental service and nutrition services. And so in the pre-employment class, they really emphasized workplace behaviors and soft skills. We did a pilot with medical assistants, and it was a little bit tough with the hiring managers to hire people, but we had people who had completed medical assistant school, but they hadn't worked as medical assistants, and so we created a refresh course so that people could, as they were working, they could get some release time as in their first few weeks to go back and practice their skills and show competency in the skills. And so that seemed to work, and it's something that we were continuing to work on with that to sort of build out what does that look like for positions where there is specific technical knowledge needed. And we really felt like we were most successful with the most entry-level jobs, and once people got into that, to help them develop skills and go back to school to move up into those more higher skilled jobs. And in terms of partners training to help close skills gaps, yes, we just as I was leaving university hospitals, we were launching a new program for patient access representatives, and we partnered with another training organization called New Bridge, and they, with Towards Employment and University Hospital's key department, set up a training program, like a 3-month training program for patient access, and then hiring people in from there. So the UH program is ongoing and continues to develop as more opportunities become available for this type of program.
Okay, another question. Is the supply of qualified potential applicants limited in underprivileged areas?
Really good question. I would say that probably yes. In the first few years, we didn't really see that because people have to want to work in those target departments, and they also have to be suited and want to work in a hospital environment. And so I think that generally you're going to come to the end of people who want to do that, but we hadn't yet reached the end of that pool of people.
Debbie, would you say that's fair to say that it's less of an issue of a limited supply of qualified potential applicants and perhaps more of a issue with the access those living in the neighborhoods have to navigate the complex application process that might be required with the healthcare system, and that it's a mismatch?
I think that the way that we designed Step Up to UH people would be able to navigate the system that we set up because we're with them the whole entire time. It's more a sense of if you have some sort of criminal background, are you now disqualified from working at the hospital? If you have an employment history where you're unable to explain, why you had a new job every 6 months, you might not be suited for working in the hospital. But people who genuinely wanted to work in the hospital felt like they were suited for both the hospital and the type of position. Towards Employment was able to provide the support for people who wanted to do that. Now, if UH did not hire people who were graduated from their pre-employment program, they have a job club where they'll help people find jobs in other positions, with other employers, because the person might just not be suited for the hospital, or maybe there just wasn't a good match at that time. And so they have it. So if they complete the program, they'll find them a job somewhere else. I think it's more that you have to get the word out, and word of mouth is really important to let other people who might not be plugged in to what's happening to know about it. So there's a lot of advertising, and so I think we haven't yet reached the end of qualified potential applicants.
One more question, or I think we have two more questions. First, what positive outcomes, if any, have you seen in the neighborhoods since you have started the job program?
So as I said at the very, very beginning, I think that, first of all, the trust that university hospitals have gained in the neighborhoods can't be overstated. I think that there's so much trust and respect for university hospitals now in the neighborhoods. People really appreciate the efforts that UH made to incorporate them into their family of employees, and word of mouth is huge with that. Also, as I said, we can see from individual basis people taking better care of their health. We can see longer lengths of employment. We can see people helping their children with their homework, making sure their kids are going to school, and graduating. We have a lot of employees whose children now are getting ready for college or going to college, where they themselves maybe didn't even have a high school diploma. So I think that in terms of measurable results, the scale of our program is too small to have an actual impact, economically in the neighborhood. But I can say that one outcome of this is that Towards Employment was able to take this model and engage the hospitality and restaurant sector to do a local hire for the hotels and hospitals that are hotels and restaurants that are in that neighborhood. And so people who might not be suited for healthcare might be suited for a hotel or restaurant. So that was really exciting to have that model be applied to the same exact neighborhoods in a different sector. And then they also did a pilot with a manufacturing company. And so I think that that's really where you're going to see the economic impact of having that type of model of local hire spread to other sectors within that same group of neighborhoods.
I think that's a great point to end on, is the one that no one strategy intervention is sufficient to change the conditions of neighborhoods that have been disinvested for decades, partly intentionally from both white flight and economic investment that's left in many of these communities, but that kind of an all-in approach in which institutions are thinking intentionally about their policies and practices and thinking about how they can take those and align or help inspire other sectors to adopt similar things around hiring, but then how also does this play into purchasing, investing, and it kind of really across the many assets that health systems and other anchors have to improve health and well-being for the residents they serve.
Perfect ending, Dave. Thank you. And thank you and Debbie very much for your excellent presentations today and all of the questions that came in and the answers that you provided. Before we close, for those of you who would like a copy of the presentation slides, you may download them from the link in your screen in the box labeled Files. It's a PDF file that you can download. Also, the recording of the program will be sent out to all registrants by early next week. Thank you very much for your participation in today's program. Enjoy the rest of your day.
Thank you very much. Ladies and gentlemen, at this time, this concludes today's conference. You may disconnect your phone lines and have a great rest of the week. Thank you.